So, very good evening, one and all. Today, it's a sheer pleasure to talk to you on this Thursday evening to introduce our esteemed panel of this webinar, CCI webinar. I'm Dr. Vijay Kumar Chennamchetty, Senior Pulmonologist and CCI Webinar Coordinator. As a part of, you all know, as a part of World COPD month this November, so CCI is doing series of webinars, and this is the second webinar, and I'm sure entire India is looking forward to learn a lot from this webinar because there is an update of guidelines that have come from Gold. And for this webinar, a star-studded panel is across India. It's an honor to have our senior colleague, our brotherly Dr. Subakar Kandi sir. Kandi sir is head of the department and professor at Kamineni Institute of Medical Sciences, Department of Pulmonology, LB Nagar. Everyone, I'm sure 90% of Indian pulmonologists have become famous after COVID-19. But sir has become famous after 2008 swine flu pandemic. Since then, it's a very well known, not only in Hyderabad, across India. So it's absolute delight, sir, and then an honor for CCI and an entire pulmonology forum across India to have you here to moderate this brilliant session which is being planned today. Next, we have Dr. Jayalakshmi Kuti ma'am. Dr. TK Jayalakshmi ma'am is a senior consultant, currently working with Apollo Navi Mumbai, and her work in chronic airway diseases has shaped the real-world practice across Maharashtra. She has that rare gift of translating science into action at the bedside. That's why Madam will be speaking today on the updated guidelines. We are really honored to have you, ma'am. Welcome.
Thank you so much.
Dr. Swapnil. So somehow there's a lot of traction towards Maharashtra today. But and Dr. Swapnil is a double MD in the sense managing director and then doctor of medicine as well. So he is the managing director of his own hospital, Narayani Hospital, and then he also heads the department of respiratory medicine at KIMS Nasik. Welcome, Dr. Swapnil Bhai.
Thank you, sir.
And next in Dr. Ravindra Sarnaik, sir. Sir is a respected name in central India. Again, traction towards Mumbai or Maharashtra. Sir has created a huge name in across central India, known for his strong clinical acumen and decades of service in pulmonary medicine. Sir's work has impacted thousands of COPD patients across the Nagpur. He has that rare combination of seniority, humility, and very deep clinical insight. Honored to have you, sir. Welcome on board.
Thank you.
Dr. Jai Kishan, sir. Another veteran pulmonologist who is a driving force of chest medicine in North India with decades of experience. Sir is from Ambala. Sir is known for handling tough COPD cases with blend of skill and wisdom that only consistently built his practice, and also his experience will be unique. Decades of experience Sir will be sharing this evening. Dr. Abhishek, my dear brother. Okay, he is one of the strongest academic voices that CCI has from Northeast India, and is always pushing for evidence-based respiratory practice. His commitment to early COPD detection and community level interventions, lot of community level interventions that he does in Northeast is truly inspiring. He is going to bring a lot of clarity, depth, and on-ground experience that many national forums rely on. We are really thrilled to have you here, my dear brother. And without any delay, I hand over mic to Dr. Subhakar sir for further proceedings. Thank you, sir.
Thank you, Dr. Vijay, for your nice words of introduction. Good evening once again. It gives me a great pleasure to welcome you once again to this CCI webinar on latest gold updates on COPD management. As Dr. Vijay has already said, CCI is doing a series of webinars in view of the COPD Awareness Month. We all know every third Wednesday of November, this year, I think 19th of November, is going to be celebrated as World COPD Day. The main aim of this World COPD Day is to create awareness among public, not only among public, our own clinicians, for early diagnosis of COPD so that we can prevent the mortality. I must congratulate CCI for taking this initiative to create this CME program, to create awareness among our own pulmonologist group on chronic obstructive pulmonary disease. We all know the chronic obstructive pulmonary disease continues to be one of the leading causes of morbidity and mortality. As per the Global Burden Report of Respiratory Diseases, COPD is the third leading cause of death globally. In coming to India, it is the second leading cause of death. We all know we are living in an era of evidence-based medicine. GOLD has designed a beautiful guidelines. A week back, it has released 2026 guidelines. So the guidelines remain the cornerstone for evidence-based management of COPD. With the latest updates, our understanding of assessment of phenotyping and treatment approaches continues to evolve, making it crucial for clinicians to stay current with these recommendations to optimize patient outcomes. We are, as a pulmonologist, we recognize that COPD management is no longer one-size-fits-all approach. It now emphasizes personalized care, early intervention, and multidimensional assessment beyond spirometry alone. Today's session will help us to appreciate these key changes and their practical implication in day-to-day practice as a pulmonologist. Actually, when we have designed this CME program, we thought of having a short overview of the COPD new updates. So Dr. Jayalakshmi has immediately offered to tell about the gold updates. I thought women are fond of gold, so that's why she wanted gold. I told she is coming from the commercial capital of India, that is Mumbai. The every day the Mumbai Stock Exchange will say updates on the gold rates, which is ever escalating. So, but in a lighter vein, she is an expert in the field who will walk us through the salient features of the latest gold 2026 recommendations, clinical takeaways, and how these can be effectively implemented in our settings. This will be followed by a panel discussion. I think the panel is already introduced to the audience by Dr. Vijay Kumar, and we have 6 panelists. Without the audience active participation, no webinar is complete. I request all the audience to post their questions in the chat box. We'll try to take up those questions as far as possible. And without wasting time, I request Dr. Jayalakshmi to go ahead and present the bird's eye view of COPD new gold updates.
Hello. Thank you, Dr. Vijay Kumar and Dr. Subhakar Kandi for the very fine introduction. Today, I am talking on COPD update, the 2026 guidelines in today's CCI webinar. Thanks to CCI for giving me this opportunity to speak here. So basically, COPD is a chronic, preventable and treatable disease with persistent respiratory symptoms and airflow limitation. It has a huge global burden and it is the third leading cause of morbidity and mortality worldwide. The etiology for COPD gives rise to the phenotypic classification of COPD. So we have the genetically determined COPD because of abnormal lung development, because of early life events, the environmental COPD, that is because of cigarette smoking and biomass exposure, because of infections like childhood pneumonias and tuberculosis, and the coexistent COPD with asthma. How do we diagnose COPD? We see the FEV1 by FVC ratio, which should be less than 0.7. If it is more than 0.7, it doesn't go in favor of COPD. And actually, as per the goal, we needn't even do the post-bronchodilator testing. However, if the patient is symptomatic and to see the flow reversibility, then we can do the post-bronchodilator testing. And if the post-bronchodilator testing gives a initial less than 0.07 and it increases to more than 0.07, it means there is a good flow response and we need to follow up this patient with repeated assessments. Important is also the LLN score and the Z scores rather than only looking at the fixed FEV1 by FVC ratios. The goal severity grading is mild, moderate, severe, and very severe, depending on the FEV1, which is more than 80% or 50 to 80%, less than 30 to 50%, or less than 30%. This is the modified MRC dyspnea scale and the CATS assessment score, which both are important in assessing whether the patient is a low symptomatic patient or a high symptomatic patient. If it's a low symptomatic patient, he goes in category A, and a high symptomatic goes in category B. And if there are less exacerbators, zero exacerbation in the previous year is category A and B, and one or more exacerbation in the previous year comes in category E. So this is a change in this year's guideline where one or more exacerbator is classified as a category E, where earlier it was 2 or more. When do you use investigations like CT scan? CT scan should be used in stable COPD patients for differential diagnosis, lung volume reduction, and lung cancer screening as per the 2026 guidelines. So this is the management of COPD in a nutshell. First, you diagnose it by basis of symptoms like breathlessness, cough, sputum production. The risk factors like smoking, environmental exposure, childhood exposure, tuberculosis, spirometry, and repeat if the spirometry is borderline. Do the initial assessment and do the initial management, that is smoking cessation, vaccination should be emphasized. Start the initial pharmacotherapy, check the risk factors, inhaler techniques, breathlessness, and manage the comorbidities, and review and adjust the treatment accordingly depending on the response to the therapy. Which vaccinations are to be used? Yearly influenza vaccine, COVID vaccine if recommended, the PCV20 vaccination, the respiratory syncytial virus vaccination, Tdap vaccination, and zoster vaccination have all been recommended for the patients with COPD. Management options. First line is a single bronchodilator for group A, LABA plus LAMA for group B, and group E is LABA plus LAMA plus ICS based on the eosinophils. So for the group A patient, only a bronchodilator, group B LABA plus LAMA, and with inhaled corticosteroid if the blood eosinophil is more than 300. The additional treatments what can be given are roflumilast, azithromycin, and biologic therapy including dupilumab and mepolizumab. Note that mepolizumab has also been included in the biological therapy in the 2026 guidelines. When do you decide whether to add the inhaled corticosteroids? If there is a history of hospitalizations, more than two exacerbations per year, history of hospitalizations, eosinophils more than 300, and history of or concomitant asthma, definitely you use inhaled corticosteroid. If there's only been one moderate exacerbation per year and eosinophil 100 to 300, it favors the use of inhaled corticosteroid. But if there are repeated pneumonia events and eosinophil is less than 100 with a history of tuberculous infection, that is goes against the use of inhaled corticosteroid. Now, what about the patient who's already on LABA plus ICS? If the patient is stable, you can continue that same treatment. However, if symptoms are high, consider escalating the care. If there are exacerbations and if the eosinophil is less than 300, consider changing to LABA/LAMA. And if the eosinophil is more than 100, consider adding the inhaled corticosteroid with LAMA treatment. So the main evidence-based treatment is triple inhalers, smoking cessation, rehabilitation, long-term oxygen therapy, non-invasive positive pressure ventilation in patients with hypercapnia, and lung volume reduction surgery in upper lobe emphysema and low exercise capacity. Overview of the current and proposed surgical and bronchoscopic interventions. So if the patient is having a bulla, emphysema, tracheomalacia, or if the patient has a giant bulla, you can do a giant bullectomy, airway stenting, coiling, thermal vapor ablation, LVRS, lung transplantation have all been suggested surgical or bronchoscopic techniques in patients with COPD. Interventions which reduce the frequency of COPD exacerbations are bronchodilators, steroid-containing regimens, anti-inflammatory treatments like roflumilast, dupilumab, mepolizumab, vaccines, mucoregulators like N-acetylcysteine and erdostain, and others like smoking cessation, rehabilitation, vitamin D finds a role, shielding measures like mask wearing, minimizing social contact, and hand washing. This is a whole list of drugs which have been used, the SAMA, LABAs, LAMA-LABA combinations, the methyl xanthines find a mention here, triple combinations, phosphodiesterase 3 or 4 inhibitors like roflumilast and ensifentrine, mucolytic agents, and biologics like dupilumab and mepolizumab. Other treatments which can be used are alpha-1 antitrypsin augmentation therapy. Antitussives, there is no conclusive evidence. Vasodilators, they do not improve outcomes and may worsen oxygenation. Opioids may be used as a palliative care, and pulmonary hypertension therapy is not recommended in patients with pulmonary hypertension secondary to COPD. Targeted therapies like ensifentrine, dupilumab have been recommended. Biologicals, dupilumab and mepolizumab have been recommended for patients with COPD with the eosinophilic subtype. And for the acute care patients, for patients in acute care requiring hospitalization, short-acting bronchodilators, systemic steroids, antibiotics, oxygenation, use of NIV for acute hypercapnic failure is the way to go. Some few new concepts have been introduced like getnomics, which is interaction between the gene, the environment, and the time through the individual's life to understand about the disease development. This shifts the focus on prevention and by analyzing the trajectory of the disease. Focus has been also placed on artificial intelligence, predictive analytics for exacerbations, for adherence monitoring. It can help in the diagnosis, assessment, and clinical management and predict the prognosis of COPD as well. Telehealth also can be used for virtual consultations. However, there are risks and limitations of AI which need careful consideration. So what are the summary of the key changes in Goal 2026? Even one moderate exacerbation can now triggers a risk escalation. This threshold is lowered to promote early initiation of dual or triple therapy, and there's a greater focus on proactive exacerbation prevention. Low disease activity is a new treatment target. Control symptoms plus zero exacerbations like we do for the asthma management. Exacerbation classifications include the CRP level, the VAS score, the heart rate, saturation levels as well. Biologicals in COPD, inclusion of anti-IL-5 pathway therapy like mepolizumab in addition to dupilumab. And COPD and multimorbidity has been considered in detail. So that is more than 2 chronic comorbidities like hypertension, heart disease, heart failure, depression, obesity, bronchiectasis coexisting with COPD. So this also term of syndemics, that means shared inflammation, which links COPD with systemic diseases. MOLT, multiple organ loss of tissue, that is muscle, bone, and blood loss. That is sarcopenia plus osteoporosis plus anemia. This leads to poorer survival. Simplify the therapy, avoid polypharmacy, optimize nutrition and rehabilitation, and AI and telehealth integration. This form part of the Goal 2026 strategy. So this is in a nutshell about the latest in the 2026 guidelines. Thank you.
for that excellent lucid presentation. You have given a bird's eye view of COPD 2026 updates. Actually, when this topic is assigned to moderate, I have downloaded 2025 guidelines and 2026 guidelines. I just saw what are the new changes only. Whatever is existing, we are not going to. Today's discussion revolves around what is new only, because there are another webinars also there. I don't know what is the webinar last week they covered. Instead of repeating the same thing, today we'll confine ourselves only to what are the new changes in 2026 guidelines. So this will start the panel. I think the panel is already introduced to all the audience. I think as per the global obstructive lung disease gold guidelines 2026 report, there are 600 million COPD cases by 2050. I think there's no change. Even the old COPD 2025 guidelines also projected 2025, 600 million cases are there. There are rapid advances in the respiratory medicine. The diagnosis of COPD is not a rocket science. In spite of rapid advances in the respiratory medicine, it was unfortunate, as per the global TB report and also Gold 2026 report, 80% of the COPD cases remain undiagnosed. I would like to know from one of our senior panelists, Dr. Sarnaik, what are the challenges, why you are not able to diagnose, what are the pitfalls, what are the bottlenecks, why you are not able to diagnose 80% of the COPD cases.
So, thank you, Dr. Kandi. This is what the observation of the Gold 2026 report. There has been data collected from the various agencies like Board, Platino, and GBD, that is World Bank as well as WHO, and it has shown that there is increased prevalence. Predominantly 70% patients are due to smoking, but indoor and outdoor pollution and occupational exposure is one additional factor which is increasing the number of COPD diagnosed in the areas where there is economic burden as well as social burden. Unfortunately, 70% of the COPD patients are underdiagnosed, primarily because the patients are underreporting or are not recognized. Maybe the symptoms are milder and they are not reporting. Few of the patients will get adapted to the symptoms and many times they don't report. So the milder diseases and the low symptoms or no symptoms, this is one important subset of patients which has been underdiagnosed. Second fallacy is at the healthcare system where the facilities are inadequate. Investigations are not available in many of the sub-centers or in the rural areas. Access to the healthcare system because of economic burden, this has been reported mostly in the socio-economically low countries. Access to healthcare, apart from that, the availability of the equipments, the quality of healthcare and the human resources, which are trained pulmonologists, especially not available in many of the regions, and facilities of training and the respiratory therapist. That is another subset which is actually predominantly noted in the report. And healthcare providers understanding of the illness, especially the diagnostic criteria. The gold diagnostic criteria are not universally implemented. There has been lots of studies which have reflected the inadequate implementation of the gold guidelines. Inadequate training in the spirometry, again technologically it is a challenging job, more again in the rural areas and the economic burden areas. Investigations apart, the referral to the specialist, especially the respiratory medicine specialization, that has been shown to be inadequate in almost universally around 70 countries. So these are the various causes which has been already shown in the table here that one has to understand, and this is what is suggested by the gold guidelines.
Thank you, Dr. Sarnaik. I think the draft has clearly mentioned broadly 3 areas where either it is patient related or healthcare system related or healthcare provider related factors. Because of these factors, which was enumerated by Dr. Sarnaik, there is a delay in the diagnosis or underdiagnosis or wrong diagnosis. I want to add one more this questions to you. How CCA can address these challenges? As an organization, CCI, how CCA can address these challenges?
Is it to be taken by me?
Me, you only.
Yeah. So I think, again, a very nice question. This is what actually every webinar's impact will be noted, that we should have maximum circulation of the new guidelines that has come up. And correctly, we have already discussed, likely to discuss every of the changes that have been updated. And of course, as we can see, predominantly the number of patients we are going to touch upon in subsequent discussion, but the case finding as well as the population screening. These are the two important areas where CCI can actually consider, because it has a huge number of very qualified pulmonologists across the country in all the corners. So we can take the message, adequate message to all the people, and we can always not only have these core kind of webinars, but CCI can also take initiative which they are already doing, and actually identifying the pockets of the geographical regions where the health awareness programs, camps can be taken up, so that we can actually expand the availability of the healthcare facilities. At the same time, we have got now technically very skilled kind of pulmonologists in the society, so they can be actually sensitized so that they can move and work for COPD upliftment, the diagnosis as well as management.
Thank you, Sarnaik. I think CCA has already started a step. The webinar is a part of this creating awareness to our own healthcare providers by disseminating knowledge about the new guidelines and how to diagnose. And one more area they can take up is can start a course on training the. I think if Dr. Krishna is there here, you can note down these points. We can start some technician training programs for pulmonary function. The spirometry, if you see, I get a lot of spirometries for reporting. None of the spirometry is not done properly. So you have to train the technicians. We can start some training program, and you can also interact with the government's healthcare systems and advise them to what are the bottlenecks at the system related things. And of course, we can also do some public health awareness camps to create awareness among the patients. So with this, we'll go to the next question. The COPD Goal 2026 has given a new screening questionnaires for COPD, which are very well highlighted in Goal 2026. How they improve detection of undiagnosed COPD? We have discussed there is a problem of underdiagnosis. So to address those underdiagnosis, the 2026 Goal COPD guidelines have given a screening questionnaires. Dr. Abhishek, can you highlight on this? What is the screening questionnaires? How they will help in undiagnosed COPD men?
Sir, Goal 26 have validated multiple this time questionnaire for screening of COPD for a high risk undiagnosed case, sir, especially in the primary care and the community settings, because this time Gold is giving more importance to the missing cases, the 80% of the cases which are missing in the society for not getting diagnosed as COPD, sir. And this questionnaire helps in diagnosis the case in the community. Basically, we have 3 or 4 questionnaire they have given this time. The capture questionnaire is there. Then there is COPD population screener is there. Then lung function questionnaire is there. Then we have Puma questionnaire and COPD diagnostic questionnaire. Among the first one, the capture questionnaire, which we know COPD assessment in primary care, especially in the primary care setting, to identify the high undiagnosed respiratory disease and exacerbation risks. Here we have 5 points based on which the patient is screened. If the score is 5, the patient is evaluated for COPD. If the question is the patient's points are 5 to 6, then we go for spirometric based on the peak flow is more than 215 male, less than 215 male, and less than 200 in female. Again, we have COPD population scanner. Here also same 5 points we have. Here also, if the score is higher than more than 5, we use spirometry in that high risk patients person. Then in lung function questionnaire, we have symptoms. We based on the certain symptoms we evaluate. If the score is more than 18, then the patient need to be likely to have high risk of airflow limitations, and spirometry has to be performed. Like this, there is again we have COPD diagnostic questionnaire developed by International Primary Airway Group, where combined questionnaire and with risk factors such as age of smoking, age of the patients have taken in account. And the last one is the PUMA, which is a prevalence study and underdiagnosis of COPD in Latin America. It was done in to diagnose COPD in resource limited settings or in Latin American country. Here they have taken the patient's age over 40 years, smoking status of the patient, respiratory symptoms, and biomass exposure. A score of 6 or greater helps the patient who are at high risk of developing COPD, and they need to be go for spirometric examination. By this questionnaire, the goal has this time tried to put the onus on the primary care, where there we can evaluate the patients to further diagnose about the COPD. So, what's the last you have asked how CCI can help? By at least training the physicians who are in the primary care, in the periphery about this questionnaire, where there is limitations of the like spirometry or X-ray, they can evaluate the patient with these questionnaires and refer the patients to the higher center to rule out COPD. So by this goal guidelines, this time has given importance to diagnose undiagnosed case by introducing these questionnaires in details.
So now all our webinars are directed towards our own pulmonologist group. So I think the CCI should also take up doing some academic programs for a general practitioners so that they can go through these questionnaires and they refer the patient early to a treating pulmonologist. Is it right?
Yes, sir.
Yeah.
This questionnaire will help then only, sir.
Yeah. I think I suggest what I think is you can have a print of these questionnaires because it may not be easy to remember these questions. You may forget tomorrow. You can paste these things in your the clinics and can do a wide dissemination of these questionnaires. So it will help to screen the patient so that the COPD can be diagnosed early. After knowing the questionnaire, screening questionnaire, are there any devices in the primary health care? You know, spirometry is the gold standard for diagnosis of COPD. But spirometry is not available everywhere, even in the primary healthcare settings. Some of the areas may not have a facility for spirometry. So let us hear from Dr. Swapnil. What are the available devices in primary healthcare to diagnose possible COPD case? Once it is called as a possible COPD, then we can refer the case to a treating physician or a pulmonologist. Swapnil, can you take up this?
Thank you, sir. So, basic available devices, if the spirometry is as you said, it's a gold standard, right? So, but every time, every center trained once first non-availability of the device, second non-availability of the trainer, and third is non-availability of the interpreter. So these all three, because of we lack all three settings at all levels of our taluka places, village places. So we can do those who are suspected cases. We can go ahead with the peak expiratory flow meters, a simple device where you can detect the serial screening. Cams can also be taken for the same, and various peak expiratory flow values we can write down, and personal best PFR we can calculate. Like one of the scores you have shown, if the peak expiratory flow is less than 250, those are the high category to be referred for the actual spirometry testing. And other testings like COPD 6, that means COPD 6-minute walk test, personal COPD 6-minute walk test, those who fall apart or get breathless while walking at least 240-meter distance, those patients we can directly post for spirometry testing. And other best device which is available nowadays is Pico 6, which is a handheld device which measures around FEV1 and FV6. So these two values, they calculate the ratio upon FEV1 upon FV6 ratio, which is a surrogate marker of FEV1 upon FVC. So these are the three available devices which can be used for the mass screening. First is COPD 6-minute walk test, second is peak expiratory flow meter, and third is PICO 6. Those who find out to be positive, definitely they have to be posted for a fully functional spirometry testing.
Okay, thank you for that update. Just for the benefit of our audience, I'm showing those pictures of PICO 6 and COPD 6. So after knowing what are all the devices which are available at the primary healthcare settings to suspect COPD and send the case early so that you can prevent the exacerbations and you can prevent the long-term morbidity and mortality. I think Dr. Jayalakshmi has clearly highlighted about the COPD was classified in 2023. It was into ABCD classification. Then it was changed to, in 2025, C and D is merged and changed to ABE classification. But there are some more changes it has made to this ABE classification in 2026 update. Dr. Jai, I think even though Jayalakshmi has given some information, I think for the benefit of audience, there is nothing wrong in knowing in detail about this. What is the new in this ABE? Any new changes were made by the 2026? Can Jai Kishan elaborate us on this?
Thank you, sir. And that is a very important thing. That for the ABE assessment tool, whatever is the latest in the say 2026 goal guidelines, that the patient should be spirometrically confirmed diagnosis. He should be having the assessment of the airflow, and there should be assessments about the symptoms and the exacerbations. Okay, so as you have rightly said, that we should be having the early diagnosis and we should be doing something for this diagnosis of the COPD. So before we can have the diagnosis or confirmation of the COPD by spirometry, the patient should be aware that if the cough and dyspnea is there or expectoration is there, then we should be. Then public should be aware of this. Then they should be knowing where these facilities are available and they should be reaching. Then we should be having a correct techniques of this spirometry. So as per the new ABE classification tool, the spirometry first, previously it was post bronchodilators confirmation. Now it was cumbersome, and so we, as per the new goal 2026, it is this screening part is done with the pre-bronchodilator, and if the FEV1 by FVC 6 is more than 0.7, then we take this is not COPD, and if it is less than 0.7, then in the ABE tool, this is that the patient is having the COPD. But there is some caveat in this, that even when the patient is having FEV1 FVC ratio of more than 0.7, even then it can be COPD if the absolute values, Dr. Jayalakshmi has said that the lower limit LNN values and the Z value scores. Then even then, if the patient is having symptoms and the risk factor, we should suspect. So spirometric confirmation is a must, one. Two, then as far as the grading on the part of the FEV1, that is not having much of these values, although it is given in the ABE from the point of the view of the management, diagnosis, or the monitoring of the disease. But for say, one mention is there in the gold guidelines, if the value of the FEV1 or FBC is between 15 to 45%, then it can be a measure for the endobronchial value, and if there is evidence of the hyperinflation. Then one very important thing that is coming up in this, that previously we used to have the symptoms based, and that was MMRC and the CAT scoring. the CAT scoring is changed now. Instead of the CAT, this is CAAT. That means combined the chronic airways assessment test. Okay. So although this is the of the GSK, but still it is mentioned as that. Now, as per the exacerbations and the hospitalization is concerned, previously in GE 2023, once ABCD was changed to ABE, there was that the patients, the hospitalization and the exacerbations were on the higher side. There should be the need, the hospitalization element and the exacerbation element. But here, now, in the ABE assessment tool, the hospitalization part has been removed. And even when patient is having the moderate or severe exacerbations of one or more than one, even then the patient is to be taken in as E. Okay. And how to have this moderate or severe values of the exacerbations? That is, in this, the VAS score should be more than 5.
Jai Kishan, I think we have a question regarding that. Dr. Sarnaik is going to highlight.
Okay.
So thank you for that update.
So there are the changes.
Yeah.
And according to these changes, we have to go for the management of these patients. Thank you.
Thank you, Dr. Jai Kishan, for that update. To cut the long story short, we can see only two things, 25, 26. I kept the slide 25 and 26. If you see 25, they have mentioned more than 2 moderate exacerbation or 1 serious exacerbation leading to hospitalization. Here, it is very simple. If you have an exacerbation, whether it is moderate or severe, whether hospitalization there or not, then it is considered as E. So very simple. Exacerbation E, that's all. Then one more change is CAT. CAT is sensing somewhat bad. CAT, when I asked CAT, what is this CAT? So they added one more A, CAAT CAT. So with after knowing these ABE exacerbations, so I think we told mild, moderate, and severe. For the benefit of our audience, I would like to know Dr. Sarnaik, how to classify these exacerbations according to the new definitions in the Goal 2026. They have given some definitions for the exacerbations. Let us hear from Dr. Sarnaik. Dr. Sarnaik, are there? Hello? Dr. Sarnaik.
He's muted.
Dr. Sarnaik,
Yeah. Yes, sir.
unmute yourself, please.
Yeah.
I would like to
Thank
know
you.
from you, how do you classify exacerbations according to new definitions in the Goal 2026?
Yes, sir.
Is it
Thank
okay?
you, sir. This is a very apt question and actually pertaining if you look at the various chapters in the new guidelines. The new guidelines 2026 specifically has changed a lot regarding the approach of the exacerbations of COPD. In fact, the reference that has come is the Paris proposal that was actually published in 2021 in the Blue Journal. And as it is in toto, along with the pictures and the diagrams therein, that has been incorporated in the GOLD guidelines. So new points of GOLD 2026, a greater focus is on exacerbation history. Even more moderate exacerbation before treatment suggests the high risk. So as Dr. Kandi also sir suggested that it is not only the requirement of hospitalization, but one exacerbation that is historically available in the history. Emphasis on achieving the low disease activity, no exacerbation and good control of the symptoms. Group E now represents all the frequent exacerbators regardless of the symptom level. So by definition, if there is history of exacerbation, that fits into E. And ABE tool in the Goal 2026 simplifies the COPD assessment and helps to choose the initial treatment by focusing mainly on symptom severity and exacerbation of symptoms. The exacerbation of symptoms, again, it has referred to the Rome so-called classification or the guidelines, wherein apart from the clinical symptoms of dyspnea, heart rate, the patient's mentation, the patient orientation, those are important criteria which are incorporated in the tabular form. It is available in the guidelines.
Okay. The take-home message is don't wait for an hospitalization. Hit hard and hit early. Start treatments, so prevent exacerbations, and you have to take initiative and start the treatment early so that we can prevent long-term morbidity and mortality. So a goal we know that in the 2025 guidelines, the goal has mentioned about the role of biologics. We are using biologics left and right in severe asthma, but as in today until 2025, the usage is limited to asthma, severe asthma, and some other conditions. But in COPD, the biologics were never tried because it was a concept that COPD is a neutrophilic inflammation. After knowing that there is an element of eosinophilic element in inflammation, where are the severe cases, severe exacerbators, in spite of optimum treatment, if there is no response, the goal 2025 has advised you can try of dupilumab. Unfortunately, dupilumab is not available in India, and there are other biologics in India. With the available biologics, whether they can be tried in COPD. So the goal has introduced some changes in the regarding the biologics. I would like to know from, I think Pratibha is taken by Animal. Swapnil, you want to take up this one? Swapnil?
Good. Yeah.
Because actually this question has to be taken by Pratibha. I have given, so you are representing Maharashtra.
Can you just repeat the question? I had an emergency call from hospital. I'm sorry.
Yeah, I would like to know in short the role of biologics in COPD and what new biologics were approved and what is the available data in Goal 2026 to say that these biologics will work.
Yes, sir. So definitely there is the upcoming role of biologics in the coming days of COPD, because as it's all depends upon all the inflammatory pathways are involved. So main biologic which is important, which is coming in a big way, is a dupilumab. So which is IL-4 antagonist, and second one is the mepolizumab. So those category of the patients who have high eosinophil count and where the triple drug combinations, still patient is getting exacerbated. We see that blood eosinophil counts are high, and in such category of patients, we can give a biological therapy in terms of dupilumab, or if chronic bronchitis, then we can think of mepolizumab. The cost is high, but ultimately it's better to give a biologic rather than repeating the exacerbation and giving steroids in such patients.
Life is more costly.
Definitely, sir.
Okay, good. Sorry.
So the nutshell takeaway point is those patients who have on triple drug therapy, and triple drug therapy with eosinophil counts are high, not responding to triple drug therapy rather than. So in such category of patients, we can go into the biologics. To support this, we have two trials for dupilumab, like is Boreas trials and Notus trials, where they have tested patients of chronic bronchitis with high eosinophil counts, where the FEV1 was between 30 to 70% patients. And in that patients, they given a dupilumab, and they have shown calculated the annual rates of exacerbations as well as lung functions in terms of pre-bronchodilator FEV1 and quality of life improvement. So they have seen that there is improvement, the significant reduction in the rate of exacerbations in such category of patients, with improvement around 60 to 100 ml after giving a biologics. Second drug to support a mepolizumab in COPD, there were 3 trials, like Matini trial. They consist of 800 patients. Again, the category of inclusion criteria was same, FEV1 between 20 to 80%. Same with the Matrix and Metrio trial. And in the observation, they have seen that annual rate of reduction was high for the exacerbation or severe exacerbations. So if we use the biologics, definitely rate of exacerbation is reduced and ultimately cost burden is reduced. And uses of the, but obviously IV as well as oral corticosteroids get reduced if we use biologics in such category.
So you mean when you try triple therapy in a patient E group, in spite of triple therapy, all the optimum care, if the patient is still symptomatic and getting an exacerbation, so you can give a trial of these biologics. And there are two biologics currently approved by FDA. One is dupilumab and mepolizumab, and DCGA also approved in India for mepolizumab. So, Swapnil, once again, one more question on this. Suppose if you have both the molecules, dupilumab and mepolizumab, which do you prefer?
Sir, as the interval is high in mepolizumab, 100 milligram for 4 weeks, and we have used it in resistant asthma cases. So we have seen that the greater reduction in exacerbations were noted practically rather than I have not used dupilumab so far in my practice. So at present, till up to time, I'll go for mepolizumab at this juncture, sir.
But the data shows in mepolizumab there is no pulmonary function improvement. All the three trials have shown only decrease in the exacerbations and steroid sparing. Dupilumab also have the same. In addition, dupilumab has an added advantage of the lung function change. The lung function change matters.
That was not tested in mepolizumab, but in practical ability in such current scenario.
We don't know whether they have, because there is no data on mepolizumab on the lung function improvement is there or not. I think I am asking one more question, sorry. Why can't you use benralizumab, which is also the mechanism of action is also same? The of course, is the anti-IL-5 agent, mepolizumab, and whereas benralizumab acts as an anti-IL-5 receptor antagonist. Why can't you try?
Again, so we need some data as the president evidence-based medicine. So tezepelumab is also in the guideline which covers all the ILs. So we need more data on same.
Yeah. So the simple fact that the mechanism is same, you can't promote that because the data is not available with benralizumab as on today. I believe they are also doing some studies using benralizumab in severe COPD of type E type with after triple therapies, exacerbation persist. Yeah, thank you, Doctor. We'll go to the next question. I think Gold has also given previous our goal of COPD management is to prevent exacerbation, to decrease in the decline in the FEV1, and to improve the quality of life. Those are the goals of COPD management. And 2026 goal, they have also discussed about the control and stability. What is the difference between the control and stability, and how does it change our assessment? I would like to know. Jayalakshmi, you have taken a long rest. Why don't you take up this case?
Thank you, Dr. Subhankar. So this time we see a lot of emphasis on prevention, on symptom control, prevention of exacerbations. So it's moving like how asthma goes, like towards complete control of the disease. So disease stability means there is no exacerbation, there is symptom control, there is low disease activity, there is no worsening of symptoms, no accelerated loss of lung function. And whereas disease control, all these things are there, that there is low disease activity, there is no exacerbation, there is no worsening of symptoms, but also there is a low impact on the patient. So the patient himself is not much affected by COPD. And to reach this target, we need to treat the patient early. That is why the goal 2026 has put so much emphasis on the early small questionnaires. So only the PFT test is not enough. So targeted questionnaire and targeted diagnosis of patients in those who are symptomatic, not general screening of the population, but screening for the targeted population. That is the smokers, those who are exposed to high environmental pollutants, those who have home exposure. So these targeted population, if we give the questionnaire and do the lung function test and identify COPD early, we can help to prevent the symptoms and help to prevent the worsening or the organized loss of lung function, which then cannot be reversed at a later stage.
Thank you. I think given a choice, you want to have a stable COPD rather than control. Stable is more
Yes.
optimistic, but at least control is the
Yes.
realistic. So, having known that, I think Gould has also given some more terms. I think Dr. Jayalakshmi has given in her presentation. There are called 4Ms. What are the 4Ms in the management of multi-morbid COPD patient? You all know COPD is a systemic disease. COPD will have so many other comorbid illnesses. So the new Goal 2026 has mentioned about the 4Ms in the management of multi-morbid COPD patients, and how does it improve the overall care? We'd like to hear from Dr. Abhishek. Abhishek.
So 4Ms, basically, sir, 4Ms stands for mentation, then mobility, medication, and morbidities. So basically, this was there for chronic non-communicable disease in elderly earlier. Now Gold has come up with this 4Ms concept in COPD also in 26. Basically, in this, they used to assess patients to improve the patient's quality of life. With treatment of COPD with inhalers and our nebulizer, we improve the lung functions. But as we know, COPD is a systemic disease, and it's have a lot of other organ involvement also. So to improve the patient's quality of life, this 4M concept has been brought, where they have asked to assess the patient maintenance goal to see whether what's the patient's mental status, whether patient is on depression side or patient having dementia, or patient is having schizophrenia or any severe psychiatric illness, which helps in improving patient quality of life by treating this. Again, by maintenance, they also try to see whether the patients have certain goals in life which he needs to finish before he gets fully depressed or dementia. Again, about mobility, sir, patients as you have seen in our COPD patients, due to hypoxia, there is osteoporosis, and patients has oxygen dependent. They usually become immobile. To improve the quality of life, the patients need to be made mobilized, or we have to assess patients exercise by 6-minute walk test. Again, as COPD, the systemic disease, patients are already on multiple drugs. There is poly drugs are going on. So we have to see all this and try to adjust patient doses so that he don't get same drugs from multiple doctors. Again, we have to check for other morbidities also, and try to address and identify and address them also. And we should also consider smoking as a disease in these COPD patients, because it is the cause of it is the root cause which is decreasing the patient's life. So we have to give importance to all these forums to improve the quality of the patients.
Thank you, Dr. Abhishek. I think Gold has also introduced another new terms. I think Jayalakshmi has mentioned these terms like mold, so syndemics. So for the benefit of our audience, Swapnil, can you take up, elaborate this, what is mold and what is this syndemics? Swapnil.
First of all, what is syndemic? So syndemic means because of the pathophysiology same, as you know, in COPD there is a lot of systemic inflammation is there, and as other comorbidities like cardiovascular comorbidities share the similar biological biopathological pathways, and because of the one already disease is setting in, another disease coming in picture because of the same pathophysiology, which decreases the outcome of the main disease. So this is called a syndemic. So this happens with COPD as well as many of the comorbidities. Like if you see in the COPD, because of the activation of the high inflammation, there occurs endothelial dysfunction or coagulation disorders or platelet dysfunctions. This increases the risk for cardiovascular comorbidities. Because of the hypoxia itself, it increases the risk of arrhythmias, and because of the hypoxia, alveolar contraction, there increases the right ventricular burden, and this increases the chances of ischemic heart disease as well. So syndemic means many comorbidities share the same pathophysiological diseases, and because of this, the outcome of the patient gets poor. This is called a syndemic. Second is about MALT, you told about, sir. The MALT is diseases with multiple organ loss of tissue. So as you know, COPD is systemic disease. So because of the COPD itself, there occurs a sarcopenia, as well as anemia, as well as renal failure. So diseases with MALT has been proposed with emphysema, with low BMI, with osteoporosis and sarcopenia. And this is all because of, if these all factors are there, MALT is there, we need to give importance to the rehabilitation part as well, nutrition part as well, rather than treating a pharmacological therapy alone.
Yeah, that is very excellent. So to address MALT, non-pharmacological interventions play an important role in pulmonary rehab, nutrition, because you said there is sarcopenia. So unless you take care of the nutrition and pulmonary rehabilitation, and COPD patient will be depressed, it will lead to other problems. So I think the goal has highlighted these two issues. Of course, even though we know this, but it has used two new terms to incorporate in 2026. I think vaccination plays an important role in COPD management, and GOLD has come out with the vaccination guidelines in the 2025 or 20. I'm not sure about when they have introduced this. So in 2026, are there any change in the vaccination policy for COPD patients, Dr. Jai Kishan? Whether have changed anything in the 2026, the same vaccines or something, any change in this?
As far as the GOLD is concerned, the GOLD 2026 has recommended the vaccination against influenza, COVID, then flu, then pneumococcal, Tdap, and the zoster. What is the purpose of this is, if the patient suffer from these diseases of the COPD, then there is a chances of the more of the symptoms, worsening of the symptom exacerbations are more, hospitalization rate are more, and the mortality rate is more. And even when the patient recovers from these, the complications and other persistence of the symptoms are there. It is other way around also. If a patient of the COPD have these also, then the impact on the pneumococcal vaccine, if it is not given, then the invasive forms of the pneumonias are more, say meningitis or empyema and pericardial effusion, and so like that. And we have already witnessed that the COVID were more severe in patients of the COPD. So for all these vaccines, there is evidence B, but the respiratory syncytial virus, the evidence is A. So as far as the pneumococcal vaccine is concerned, or any other vaccine is concerned, you have to have a application of the local guidelines or the CDC guidelines. Although in India also there are the guidelines for the vaccinations, but they are the old one, but the CDC are the new one. In case of the pneumococcal vaccine, we have to go for now the single dose of the say PCV 20 or the 21. But if the patient has already received the PCV 15 or PPSCV 23, then we have to give the second dose of the PCV 15 or the 20 in case of the PPSCV 23, the polysaccharide vaccine. And in case of the PCV 13, again, you can give the PPSCV 23 or the PCV 20. But here, one thing very important is that you have not to give the polysaccharide PPSCV 23 vaccine now as in a naive patient. And one thing you should keep into mind while giving the pneumococcal vaccine, that if the patient is having allergy to the Tdap, then it is contraindicated. So in case of the flu, this is again a very common and occurring, and we have to give the one shot every year to these COPD patients. And what is the timing of these? The timing as per the CDC guidelines are varying in the southern and the northern hemispheres. In the southern, it is April to June, and in the northern, it is in the case of the October or the December. But in Indian setting, it is pre-monsoon or the pre-winter. So in case of the pre-monsoon, it is June to August. And in case of the winter, it is September to October. But here, most of the time, the vaccine is usually not available. It should be taken 2 weeks before the onset of the season. But if it is not available, then it can be taken on later on also. And it's better to have the vaccine rather than not to have the vaccination because of the delay in this. So we should be having these vaccinations, and the inactivated trivalent vaccine and live attenuated influenza vaccines are there. And in patients, if it at all they are suffering from the influenza also, then we can try the drugs also, and that can also be having prevention. But the drugs should be started within 2 days of the start of the illness, and they should be oseltamivir, zanamivir, the amantadine, rimantadine, and these type of the drugs can be there. As far as the zoster is concerned, the Shingrix is this a vaccine, and we have to give the 2 doses, and they should be 2 to 6 months apart. But contraindication to the zoster is that patient should have not the previous history of the encephalopathy. And in case of the zoster, if the patient of the COPD suffer the zoster, then the complications of the zoster are more, and especially the post-herpetic neuralgia is also more. So we should say, get this. Then in case of the Tdap, every pregnant woman is recommended the Tdap. But in case of this COPD patient, if the patient has already not received Tdap, then it will be given the first dose and the second dose after 4 weeks, third dose after 6 to 12 months. But in case the patient has some wound and mild and clean, then the booster is to be taken after 10 years. But if it is a major wound, then after every 5 years. Then the only vaccine where there is the evidence A, grade A, that is the respiratory syncytial virus administration, and that is only 1 dose is to be given, and it should be avoided in these females, and we should be if the patient is already vaccinated, we should not be having the additional this RSV vaccine. As far as COVID is concerned, that we have already these vaccines, and now COVID is not that much there, but still the guidelines are there that the patient of the COPD should receive the COVID, and there should be the booster. Even the 5th or the 6th boosters is also recommended by the CDC guidelines. So the vaccinations are 6, these should be given, and beside these, the other vaccination, if need be there, they should be given. But Gold has recommended these 6 vaccines, and if we give this, then the exacerbation, hospitalization, and the complications are decreased of the COPD and also of these vaccine-related diseases. Thank you.
Thank you, sir. I think there are 6 vaccinations which were approved in COPD 2026. The only change I found between 2025 and 2026 is the respiratory syncytial virus. The age limit, previously it was 60 to 75. Now the new guideline says from 50 to 75. That is the only change I have found. Otherwise, all the vaccines which were there in the previous guidelines are also mentioned here. Having known this, sir, I want to know from every panelist in this today, are everyone giving during our routine practice all these 6 vaccines? I will start with the Jai Kishan only. Sir, how many vaccines you are giving?
Here
Now,
are the
adult
barriers
vaccination program is taking in a big way.
Yes,
Out
yes.
of these 6,
So definitely all the 6 vaccinations, all those recommended, but the physicians are not giving, the patients are not getting, and there are the barriers. One, the physician not very much aware of this. One, two, availability is again an issue. That cold chain formation is issue. Three, that the patients has to spend for the adjusters or the pneumococcal vaccine and like that from the pocket. So if the patient has to spend from the out of the pocket, then this is a barrier. And in case of the influenza vaccine, say the availability is a issue, and even they say when to give, and pre-monsoon or pre-winter, or in the northern hemisphere vaccine or the southern hemisphere vaccine, that is a barrier. So all the 6 vaccines, I don't think that any of all of the panelists sitting here are giving in routine to the patients, and patient susceptibility is there.
Jayalakshmi, you can't watch for them. Let us hear from them only. Jayalakshmi, so what is your experience?
Using the influenza vaccine routinely. Now the trivalent vaccine has also come, which is about half the price of the earlier vaccine.
Yeah.
Which is really helpful.
So it also covers now the COVID strain also. There is no need to give a separate COVID strain. Yeah. Yeah, go ahead.
So then we give the pneumonia vaccine for all. Now the PCV20 is also available, which needs to be only given as one single dose, which makes it very much simpler. So we are using that. And also we are giving the Shingrix vaccine. So this has to be given as 2 doses. The RSV and the Tdap only for those who are requesting we are using. RSV I have not yet started giving the vaccine.
RSV is available? I'm not sure the RSV vaccine is available.
I have not used that vaccine.
Yeah, okay. Yeah. Other panelists can comment on anything there, the way they are changing. Sarnaik?
So I think I think I have the same consensus. The influenza vaccine and the pneumococcal vaccines are the one that are usually, depending on the severity and the age of the person, and of course history of exacerbation.
Yeah.
But the RSV vaccine, even I have never used.
Can I add a few words?
Please.
So we should learn from nephrologist or a transplant physicians. It is a must protocol. So it should not be the mental barrier for us. We should not decide how much the money in the pocket of the patient does they have or not. It should be the protocol in our practice that we should at least give all these vaccines. If the patient is not affordable enough, once they get admitted, if they have cashless, before the discharge, we can try to vaccinate them as much as we can possible. So that is another way to vaccinate them indirectly, so that they does not have to spend from their pocket. But at least we have to keep in our OPD file cross-check on the vaccination part at least.
Can you do concomitantly, or if there is any gap?
2 vaccines can be given concomitantly, sir. The pneumococcal and flu. Others we can give up in the follow-up as well.
Yeah. So, any other panelist has a difference of opinion? Yeah.
So I agree with the Swapnil sir's thought, sir, that we should be active in giving the vaccine, sir.
Yeah.
Because often we see patients when they get admitted due to this influenza or any pneumonia, then they pay more.
Yeah.
If you instead of getting treatment, prevention will be better.
Yeah. So I think again the CCI rules comes here to create awareness. One of the challenges Dr. Jai Kishan is told is that there is no awareness among our own clinicians and also public to create an awareness. I think out of pocket expenditure, one exacerbation costs 100 times the cost of a vaccine. So I think we have to disseminate this knowledge and see that the adult vaccination program should take in a bigger way, and see that our COPD patients should not die of exacerbations because of lack of vaccination. So after knowing vaccinations, so we'll come to the last, the critical care management. I think our patients should not come to that critical care management. So Dr. Sarnaik has done DM also, has a lot of exposure for critical care management, and he is also running an ICU in his hospital. So, is there any change in the critically ill COPD patients which were mentioned in 2026 guidelines, Dr. Sarnaik?
Yes, actually, as I was suggesting, in the classification itself, there has been great change in the classification of the severity of this COPD patient in the current guidelines. So likewise, now there is immense stress put onto the patient's clinical symptom score, the blood gas analysis, and of course, other ancillary supportive investigations like CRP to classify these patients and then decide the severity, mild, moderate, and severe. So especially the patient who are not hospitalized, they are managed ambulatory, they are mostly the ones who are not critical. So the question pertains to the patients who are having moderate and severe COPD, and there is a definition in self-inclusive now, the patients who are with respiratory failure and with respiratory muscle fatigue, of course supported by the ABG. So if we look at the current guidelines, the majority of these patients need to be in the hospital and preferably in the
When do you
ICU.
advise the ABG? When do you advise ABG? Because
A
sometimes patient may
who
look.
is yeah. So
Yeah.
the patient who is having moderate exacerbation, the blood gas is a part of the investigation and classification.
How does
So
it help you?
that is primarily to decide whether patient is hypoxic or associated hypercapnic. And that is going to decide whether how long he can be put onto the non-invasive ventilator or likely possibilities of intubation. So to subclassify these two subsets, the current guidelines suggest that patient needs to be in the hospital, preferably in the ICU, and of course to be supported by the blood gas analysis. And then basic principles of the bronchodilator, corticosteroids, antibiotic would remain same, but oxygenation again has to be titrated as per the individual case and the associated comorbidities.
Are there any change? It was mentioned in the oxygen devices which were used for the COPD management. Previously, I think the LTOT and oxygen, I think 2026 has mentioned HFNC also can be tried before going for the invasive ventilation.
Yeah, non-invasive ventilator HFNC has been suggested, but this has been included in the guidelines. But otherwise, the basic protocol of managing critically sick COPD would be same.
Same. I think any critical care. It's okay then. Thank you for that update. So I think Dr. Jai Kishan in one of his questions answer, the guidelines were drafted by the people who have no exposure to Indian settings. The guidelines are only to guide. They are not a Bhagavad Gita. We have to be changed according to the local circumstances, local availability, local infrastructure, and resources. The guidelines have to be changed. And the Indian Society has drafted some guidelines, Indian guidelines on COPD way back in 2010. After that, there was no update. So I would like to know from Dr. Jayalakshmi, so how you can help on this.
So basically, much part of India has a resource limited setting. In the cities, there are resources. So the guidelines we need to modify. The thing is, right now, even the guidelines have also helped by giving questionnaires, by saying that we need to target the population who are more at high risk.
Suppose
Also,
if you are asked to draft Indian guidelines, what changes you suggest to the existing 2026 guidelines? Suppose Jayalakshmi was assigned the responsibility of, she was there in the guidelines committee for writing. So what changes you suggest? What you are going to think of?
So here we don't have such universal access to the spirometry. So starting with the history is correct. starting with examination is correct. They have also suggested to do CT scan for all patients, but this may not be possible in our setup because we may not be possible. Maybe it's possible in the metros, but not possible outside for doing a CT scan for all patients for really coming to the diagnosis of COPD. We'll have to limit ourselves to the X-ray. Also, we need to use the peak flow meter more extensively in addition to the history, the questionnaires, and also targeting the population which is more at high risk, say those who are exposed to chula exposure, or those who are smoking, or those who have environmental smoke exposure, COPD, past history of tuberculosis. So these would be the high risk population to screen. The peak flow would play an important role. The spirometry will play an important role. Even in the Indian setting, we need to see to it that the low-cost spirometers are available in the major areas, and also the training is given for that, like we have mentioned before. Even the vaccination schedule, we have this whole 6 vaccinations. Maybe we'll have to restrict it to the important vaccinations. So give more importance to some, rather than, because Shingrix vaccine is like 18,000 rupees for, it may not be possible for everybody to take it. So although we can recommend it, but we need to focus more on the ones which are like the low hanging fruit, the flu vaccination, which really saves a lot of lives. We have seen so much decrease in hospitalization in the patients who have taken the flu vaccine than not. Similarly, for the pneumococcal vaccine, which protects around 70% of all the pneumonias which can come. So we should have a more focused approach. At the same time, there has to be more focus given to the smoking cessation, prevention of environmental exposure. So these kind of things, prevention will play a very major role, because we will not be able to treat these patients once the COPD gets developed. It's one of the diseases with only the inhalers which become very difficult to treat. Only certain extent it can be treated. It cannot be fully cured. Similarly, as far as the treatment is concerned, we cannot focus so much on biologicals. Firstly, they are not available and they are expensive. So the focus will be more on inhaled medication, the cheaper inhaled medications which are available, and how to use. And so this way we should go for the Indian population.
Okay. So I think our problem is we see more of non-smoking COPD rather than smoking COPD. Unfortunately, enough importance is not given, particularly in a country like India, where tuberculosis is one of the major global health problems in India. So we see a lot of post-obstructive, post-TB sequelae as TOPD, what we call as TOPD. We have to work on this, whether TOPD is a separate phenotype when compared to smoking COPD, whether the same treatment works for TOPD also. So you have to do some basic research. I think ICMR has started a project. We're asked to be a part of that project. So see that we can have our own guidelines, particularly addressing post-TB sequelae, TOPD, and biomass fuel. I think Dr. Salvi has given a lot of literature on this. So these things have to be incorporated into Indian guidelines, and see that what best we can do, how to address these issues. And as you rightly said, India is a resource-restricted country, so we have to see other alternatives to spirometry, and the HRCT chest, whether you have to use as a routine tool or when do you use HRCT. These are some of the things which we need some evidence and some clarity in the Indian context. By the way, how many of you are using HRCT routinely in our COPD management? I would like to know from every panelist. And if you are doing HRCT, why you are doing HRCT? We start from Swapnil.
Sir, I'm not doing it as a routine practice.
Yeah.
If the patient comes to me, once the first is PFT, whether the physician or other chest physician has done a pulmonary function test fully, and second is compliance or adherence to the medication, and third is technique.
Mm-hmm.
If patient satisfies all these criteria and patient is still symptomatic and coming to me for second, third opinion, then HRCT, 2D echo are the first foremost two things which I advise. Not as a prima facie as a first investigation, unless some other feature suggestive of any infection or malignancy is there. As a part of to document emphysema or bronchitis, I don't do HRCT, sir. So 3 checkpoints. One, complete PFT has been done. Patient is taking medications and is not improving. And check another technique is correct. Then only there remains a criteria. What else is obstructing us to know patient's outcome? So for the same thing, I do HRCT and 2DCO both as part of a further investigation tool.
Other panelists, Sarnaik, you advise HRCT? So
Please mute. Dr. Sarnaik, you're muted.
yeah.
So, sir, can I?
Because yeah, please, sir. Everyone
I
can.
usually advise the CRT, HRCT, or the CCT in patients of the COPD. First, there is a clubbing to rule out the underlying bronchitis, to rule out the underlying CA. And if these symptoms are out of proportion, then they say these parametric values, then we are advising. Okay. And then as far as the TB is concerned, beside the TOPD, at the outset also, we in a patient who is having cough expectoration, breathlessness, and the other symptoms, we should rule out the TB as a part of the NTEP also. Okay. And what I feel that there should be a guidelines which should be, say, based on primary healthcare setting, secondary care setting, and the tertiary care setting. So those who are in the primary care setting, say we had in the old guidelines, instead of the CURB 65, we had CRB 65 score for the admission criteria. So these can be different for the different settings. And once the primary care setting person is suspecting and is not able to say confirm the COPD, then he should refer to the secondary. And once management is not there at the secondary level, then it's going to be at the tertiary level also. So if at all we are preparing the guidelines, and India is a vast country, the most of the population is there in these rural countries. So primary healthcare center guidelines, secondary and the tertiary care center guidelines should be there. Those who can pay, they can have in the private metros and other hospitals, and their guidelines may be different. Okay.
Anyone? Just Sarnaik, do you want to have some? Because if you ask for it, what is the idea of doing that HRCT? I have an opportunity to attend the recent American College of Chest Physicians Congress at Chicago. So in fact, they are incorporating this HRCT into their COPD guidelines. The main goal of doing an HRCT is, in fact, the data shows the HRCT is more sensitive, as per their literature they have produced, more sensitive index when compared to the lung function. The changes in the HRCT, if you are an expert in reading the CT, you can identify particularly emphysema phenotype. You can diagnose early. The advantage of if you diagnose hyperinflation, those are the candidates you can consider for the pharmacological treatment like lung volume reduction surgery, endobronchial valves can thought of as one of the modality of treatment. That is why they are incorporating the HRCT also into the. And one more advantage is lung cancer screening. For example, the low-dose CT is one of the tools to screen the lung cancer. And lung cancer and COPD have both common risk of smoking. So when there is a history of more than 15 pack years, or if 20 pack years, and the age between 50 to 70 years, and suppose if a person start smoking at the age of 15, these are the high risk candidates. We have to do a CT scan. It will help not only to diagnose the early COPD and also helps for a cancer screening. So
we are using the HRCT quite routinely, being a tertiary care center for our patients for the COPD for these reasons, as you mentioned.
Yeah, okay. Thank you.
And again, sir, in my setting, sir, most of the patients who can afford, I get in our place privately done. But nowadays, in government civil hospital also, in our place, CT scan is being done at very low cost, 10 rupees.
Now I see most of the patients are coming with CT instead of
Yes, sir.
X-rays. Our
From their
postgrad
center.
is also writing CT first, and they forgot chest X-ray. They are doing for everything CT. Of course, you have to use it judiciously. So these are the when you order a test, you must have why you have ordered. I always ask my postgraduate, when you order this test, you have to substantiate what additional information you got over chest X-ray. You have to ask ourselves. So I think we have come to the almost the last question of the panel. We have a young pulmonologist, Dr. Abhishek Agarwal. Now everywhere AI, artificial intelligence, I think in soon they will, artificial intelligence will replace the human brain. I don't agree with it. In fact, every time I always, every day I will fight with AI today. Today I have posted one X-ray, asked to comment. Actually, it is a diaphragmatic hernia X-ray I posted. Please comment. I asked ChatGPT. So it has completely missed. It has given a right upper lobe fibrosis, something like that. When I pointed, always I used to teach AI sometimes. Now it became a hobby. There is a diaphragm, the left dome, below the left dome, there is no gastric fundus shadow. Have you not noticed? There is a retrocardiac air fluid shadow. Have you not noticed? Then, yes, I noted it is a diaphragmatic hernia. So I think whether this AI can be implemented in COPD, of course, AI has its own limitations. If taken to the optimum use, I think AI will definitely help. But AI is not the end of all. The AI can never replace physician. Even another 20 centuries also, AI can never replace a physician. So I want to know from Abhishek Agarwal, what was discussed about the role of AI in COPD in 2026 guidelines?
So in as we last few years we are hearing everywhere AI. It is going to replace doctors, engineers from the society. But as you have said, next to impossible to replace human touch for anything. You need human touch to know the patient's mental status, to know what's exactly patient status is there. No doubt AI can help us in a lot of way. It can help us to diagnose misdiagnosed case, undiagnosed case, or the patient who have not been diagnosed, which help in early diagnosis. It can help us in predicting flare-ups. It can help us in monitoring adherence and symptomatic follow-up of the patient. And in fact, with AI tools, we can have personalized treatment. And it also help us for a long-term follow-up of the patients, whether patient is having good compliance with the medicines or not. Now we have AI-based a system which can help us reading in spirometry and CT scan better and faster. But how much it will be equal to the human brain, it's difficult to comment. Now it can help us in predicting the exacerbations by patients by analyzing the patient's breathing data, activity, and symptoms to predict whether the patient is having going to have exacerbations. And this allows the doctors to have adjust the medicine early and prevent hospitalizations. Now we have new AI based. We can have smart inhalers where we can see the dose of medicines, whether patient is taking medicines regularly or not, with a chip in the tiny sensor in the device, smart inhalers, which can be sent to the doctor's phone or a clinic by app based on apps, which can help us in correcting the patients regular taking the medicine and prevents exacerbations and helps the proper adherence of the patient. Now we can have remote monitoring of the patients based on this AI. Sir. Now, if by AI based app, we can have also have patients follow up. We can see whether the patient is taking his regular medicines or not, and we can adjust his medicine dose. And we have certain digital decision support tools also based on AI, which can doctor can monitor the patient digitally from their distance. There are like we have example of AVO clinical support, clinician support platform, which used with gold guidelines. Sir. But still, there is a long way to go based on AI to have this in a country like India, because we have still resource limitations in periphery area. How to use and how much it will help us. It will long way we can, sir, it will take to guide us, sir.
Thank you. I think no discussion is complete without taking up the questions from the audience. I can see in the chat box from Tridip Chatterjee from Maharashtra, Mumbai. I think is a comment only. It's important to do the CT properly with expiratory plates, etc. in the COPD to be of very use or else no use. I think his impression is that you have to do it in the expiratory phase CT to detect the air trapping. I think I totally agree with him. Any other questions? I think there was only one or two.
So he had asked one more question.
Yeah, I could not see that. Can you see that, Lakshmi?
Yeah, he had asked one more question on regarding the role of bronchoscopic procedures, LVRS, etc. What was the guideline? So COPD.
You want to take up that? Okay, go ahead. Yeah.
So there is a specific slides for that from the goal 2026, and they've said that in patients who have bullectomy, then airway stenting, the coil therapy, thermal vapor ablation therapy, lung sealants, lung volume reduction surgery, lung transplantation, all have a role in the selected patient. So they have suggested to go for all these bronchoscopic procedures for this subgroup of patients. He had also asked about the iOS. So Dr. Tridip, only regarding the PFT it was there, but regarding the iOS, I was not able to find any guideline in the 2026.
The advantage is the iOS can find out the small airway disease, but even in normal persons also there can be a small airway. You can't say the 100% is a COPD. And adding to the bronchoscopic procedures, unfortunately, the endobronchial valves, the Jeffer valve is not available in India. In the Western countries, they are using left and right for their it acts as definitely one of the problem with these endobronchial valves is sometimes they may migrate, cause a problem. So I think there is a role of bronchoscopic thermal ablation, lung volume reduction surgery, coils, valves, definitely it will help. And there is one more question from Daljit Singh from Punjab. Recommendation for boosters and the interval in pneumococcal vaccine. Jai Kishan sir, it is your question.
I've already given him the answer in the
I think you already answered this because now we are fortunate to have a PCB 2021. I think if you give one lifetime, that is enough.
Okay. So as far as bronchoscopy is concerned and the TB part, so in case of the tuberculosis, the post-TB COPD is there. But beside that, if there are strictures because of the endobronchial tuberculosis, then the patient may have the rhonchi. The local rhonchi may be there. You may give any amount of the steroids. The patient may not improve, and many times it may be the cause for the reactivation. But we have done some cases where we have gone for the bronchial dilatation with the bronchoscopy, and then the patient's symptom improved, and even the patient, the lung also expanded. So it can be there to some extent in the bronchial strictures because of the post-TB, endobronchial TB.
Okay. Swapnil, are there any new drugs for COPD?
Yes, sir. There are new drugs like bronchiectasis, I just forgot the name, sir. So the new one practically.
Yeah. So the ensifentrine is the drug. Actually, unfortunately, that is not available, this PD5 inhibitor. So we can use it is available in nebulized form. They give each ampoule contains 2.5 ml. It is available particularly in after discharge you can use this nebulized form. The disadvantage is some of the patients can get a reflex bronchospasm, and some cases can have a diarrhea.
Practically, we are using ardostin as well, sir. And as
ardostin is a mucolytic.
Practically available right now.
Yeah. So, anything?
Recently, one of the company told about that the triple therapy in nebulized form, sir.
Yeah.
In a single respule, sir. It's also is in the pipeline. I think it will be launched by next month, sir. Whether its efficacy anyone has used.
Sir, no, it's in the pipeline.
No, actually, the company has told that by the end of it has been in trial, some instrument trials, sir. And by the end of this month, they are going to start in India, sir. Like glycopyrrolium, formoterol, and budesonide, sir. But there is doubt how glycopyrrolium can be stabilized with formoterol. One has to be kept in cold chain, and one it's outside cold chain in nebulized form.
Dr. Jayalakshmi, you told in group A, I think, you said only one bronchodilator. Given a choice, you use LABA or LAMA. What were the guidelines says?
LAMA.
LAMA, yeah, that's.
In case of the stable COPD or otherwise, we should be using the LABAs and the LAMAs. But in case of the exacerbations, we should be using the SABAs and the SAMAs.
That's why I told group A, sir. There are no exacerbations, group A.
Okay.
Yeah. Most of the patients, how often, what is the problem of, I think that the literature shows if you use inhaled steroids, we get pneumonias. For the fear of pneumonias, they are not using inhaled steroids, even in exacerbation also some of the, what is your comment on this? Anybody can answer.
Although there are higher chances of the pneumonias with the use of the steroids, but if we ultimately see the complications of the pneumonias as a whole, then the pneumonias are less. But if the inhaled steroids are not used, then the patient exacerbations, mortality, respiratory failure rates will be high. So in a patient of exacerbations, and when the patient's symptoms are not getting controlled, then you should be using inhaled steroids in a E group of the patients.
What are your thoughts, Dr. Jai Kishan? You are a senior pulmonologist. When you are undergraduates, we have using left and right aminophylline drip and theophylline. So what is the current role of these theophylline?
So some of the others in my GI unit, at least, we are not using. But some of the rules can be that it can have the mucolytic properties also. And very rarely in a desperate conditions where the patient is not responding, you may, or whether the patient is not able to afford, or where the patient is not able to go for the inhalation therapy, the DPIs, the MDIs, but the nebulization can be given in a patient. Now the domiciliary nebulization is an alternative, or even if you teach the technique of this inhalation to the patients, then this should not be an issue. So we are not using much of this.
Abhishek, can you use these digital tools, particularly for pulmonary rehabilitation? We don't know how the patient is doing, how to train the patient and teach the patient and to see the patient. Can this digital technology helps?
So yes, definitely, sir. As you know, pulmonary rehabilitation is not widely available in our settings. It will definitely help in follow-up of the patients and teaching the patients for the pulmonary rehabilitations. And we can monitor the patient also whether they are continuing their pulmonary rehabilitation part at home also, sir.
And also you can use how he is using the inhaler
inhaler technique also we can, when symptoms also we can monitor, sir, with improvement, sir.
I think there are no more questions from the audience, and if there are any panelists, I think I want one quick comment from each panelist. Dr.
Sir.
Yeah, please.
Excellent moderation, sir.
Thank you.
Hats off to your all
Thank you.
experience,
Thank you, boss. Thank you.
shown in your all models, sir.
Yeah.
So you chose each and every panelist to a specific depend upon their experiences.
Yeah.
So thanks a lot for giving opportunity, sir.
Yeah.
To a nutshell, gold is developing year and year. We should also try to modify ourselves in our routine practice. We, as being junior to you all, we should also learn to what not to be done rather than what to be done. And non-pharmacological therapy has to be a routine protocol in our practice. That is a takeaway from my today's talk will be, sir. Thank you.
Abhishek, one-liner.
Sir, one-liner, sir, S4M, which we have discussed, we should follow in our all COPD patients, sir.
Yeah. Okay.
Thank you,
Jai
sir.
Kishan, sir. One
So
single
we should
line.
be creating the patient awareness, the public awareness. We should be stressing upon the policymakers, the politicians about the availabilities of the facilities at the peripheral level. And we should be, training the physicians, and we should be telling to put all these things into practice rather than knowing the theory only. We should not be reluctant in going for the spirometry and other techniques and using these vaccines. Thank you.
Jayalakshmi.
So for prevention, smoking, air pollution, indoor pollution, all these things should be stressed because COPD can be prevented, but treatment is very difficult. So vaccinations, these play an important role, and not to forget about pulmonary rehabilitation.
Sarnaik, sir.
In fact, the guidelines stresses majority of the differential diagnosis. Like many times somebody is labeled COPD, that tag should not be continued for a clinician. Anybody who is not responding adequately has to be re-evaluated for differential diagnosis. At the same time, the morbidity and mortality, was the guidelines has suggested, is predominantly decided by the comorbidities. So I think one clinician should be very vigilant in associated illnesses, that is going to be actually looking at the outcome of the patient and the clinical, what we call as stable COPD in the management.
Okay. Thank you. I think it is appalling to know, in spite of so many advances, even today, 80% of the cases remain undiagnosed. I think once you find a solution for this, and we see a meaningful change in the COPD patients, I think these discussions will go on forever. And I think we have to see the smile in the patients of COPD. And Dr. Jayalakshmi said, first prevent COPD, if at all, by any means, if he gets COPD patient, see the smile in him, and don't neglect and see that he has his own quality of life. With this, are there anyone from the organizing team? I thank all the panelists, Dr. Sarnaik, Dr. Abhishek Agarwal, Dr. Swapnil, Dr. Jai Kishan. Unfortunately, Dr. Pratibha, because of her ill health, she could not join. I profusely thank the organizers, particularly CCI. Dr. Krishna is my brother, who is doing a wonderful job, whether it rains or shines. Every Thursday, there is one webinar in CCI webinar, and I think it's very difficult to continue the same thing for the last 3-4 years. It is marvelous. I think it should enter the Guinness Book of World Records by meticulously doing these webinars every Thursday. Thank you.
Thank you, sir.
Yeah.